Okay, let's get started. Welcome to the National Alopecia Areata Foundation's webinar, Alopecia Areata 101. Joining us today is Dr. Amy McMichael, Professor of Dermatology at the Wake Forest School of Medicine. And I'm Lisa Anderson, Senior Director of Research for NAF. Before we start the webinar, I'd like to cover a few housekeeping details. We've disabled chat for this webinar session, but please post questions for Dr. McMichael in the Q&A section. If you can, please keep your questions general for the benefit of all audience members. This webinar is being recorded and all registrants will receive a link to the recording via email. And finally, please share your feedback with us. At the conclusion of the webinar, a link to a short survey will pop up in your browser window. Please complete the survey there. This webinar is part of NAF's You Are Not Alone Education and Empowerment webinar series. NAF gratefully acknowledges the support provided for this webinar series by our partners Eli Lilly and Company, Pfizer, and Sun Pharma. I'd like to start today's program by telling you a bit about NAF and our mission. The National Alopecia Areata Foundation is the leading advocacy organization for alopecia areata. NAF's mission is to support research to find a cure or acceptable treatment for alopecia areata, support those with the disease, and educate the public about alopecia areata. NAF's vision is an empowered community with a choice to embrace or live free of alopecia areata. To learn more about NAF's support resources and research and advocacy activities, or to join us as an advocate or a supporter, please visit our website at naf.org. And now on to today's webinar, Alopecia Areata 101. We're very pleased to have Dr. Amy McMichael with us here today. Dr. McMichael is a professor in the Department of Dermatology at Wake Forest School of Medicine in Winston-Salem, North Carolina. She has held leadership positions in the department for over 20 years, including as residency program director and department chair. She is a leader in her field, including her roles as past president of the Skin of Color Society and past president of the National Medical Association Dermatology Section. She currently serves as a board member of the American Academy of Dermatology and is a member of NAF's Research Advisory Council. Dr. McMichael's clinical and research interests include hair and scalp disorders, psoriasis, and skin of color. Dr. McMichael, thank you so much for being with us today. I'm going to stop sharing my screen and I will turn it over to you.
Thank you so much for that warm welcome. It is a real pleasure to be here today. I'm going to share my screen now and to move us up a little bit so that I am not in the way. So welcome everybody. I'm going to put on the slideshow and we're going to start right now to talk about updates and common myths about the disease and treatments. And we'll go through about a half an hour or so. So I want to leave ample time for questions. So most of you probably already know alopecia areata is a disease of patchy hair loss, often just affecting patches, but we all know that you can have all kinds of appearances. We also all probably know that it's an autoimmune disease of the hair follicle, where you can have hair loss from any area of the body. Now, many treatments are focused on scalp involvement, but that's not the end of hair. Of course, we have eyebrow involvement, eyelash involvement, and every place that there's hair in your body can be involved. We know that the etiology is at least one part genetics, and there's some unknown amount of part from environmental things that we just haven't uncovered yet. And as I said, the patterns of alopecia areata are many. You can have the patchy variety, which we see pictured here in the bottom of my screen, totalis, where the entire scalp is involved, universalis, where all the hair on the body is involved, ophiacis, which is in the posterior scalp, so down at the nape of the neck and kind of around behind the ears. And then some very interesting person thought, well, if you have hair in those areas, in the nape of the neck and the posterior ears, but not other places, it's the opposite of ophiacis. So it's ophiacis backwards, or sisypho. And then you can have a diffuse version, which is really difficult to diagnose and is usually a diagnosis of exclusion, oftentimes being made by biopsy. The lifetime risk of alopecia areata in the general population is about 1.7%. And we do have clinical signs that we can see as dermatologists. Now, some people who are not clinicians might not be able to see all of these things, but when we look at the scalp, we can often see exclamation point hairs, and I think I might have a picture of those later, but they are indeed shaped like little exclamation points, and they're places where the white blood cells attacked the hair follicle and stopped its growth while it was sort of in an active phase. So that's a marker of active disease, as is a positive pull test. When we pull at the active margin of a patch or area, it can affect pigmented hairs more readily, as you can see down in the bottom right corner as well. The hairs can regrow in gray or white, and you can have pitting and different kinds of changes with thickening of the nails. Now, while alopecia areata is an autoimmune disease, we know that it can be associated with other autoimmune diseases. It doesn't have to be. Many of our patients are quite healthy and don't have any associated diseases, but you can see really any autoimmune disease. And I've seen everything that's listed here and more. So when we talk about nomenclature, we've already talked a little bit about, the type of hair loss that people have. This areata is sort of the overall umbrella term. So we call it alopecia areata, but we know some people have patchy disease, some people have totalis, some people have diffuse, but it all still fits under the umbrella of areata. And when you just say, I have alopecia, that could mean anything. We know that there are many, many forms of hair loss that are not alopecia areata. So when you're talking to your doctor or talking to anyone about treatment, they have to speak to you distinctly about alopecia areata, because there are totally different treatments for other forms of hair loss. Now, sometimes when we look at the scalp close up, we can see redness. We've already talked about exclamation point hairs and pigmented hairs and positive pull tests. And I've just shown a close up picture of a patient with ophiasis and a patient who has involvement of the nails. We often see nail involvement in children, but we can see it in adults. And it's usually little tiny pits, but you can see linear marks, you can see thickening, you can see a lot of different things. So we always check the nails as well as the scalp and other areas. Now, there are a number of forms of hair loss that can look very, very similar to alopecia areata. As a matter of fact, as someone who does alopecia areata studies, I've often had other patients come in and say, well, I want to be in your study because I have alopecia. Well, they do have alopecia, but they don't have alopecia areata. So one of those is something called traction alopecia, seen primarily in women of color, of African American descent, or African descent. And generally, the giveaway is this little bit of fringe that you can see here on the frontal hairline on the top left photographs. It's also, there's not just significant, there's the whole area is not covered. You see that there's some little fine hair growth in there. So you have to be a bit of a detective in order to get the right diagnosis. If we move over to the patient who does have alopecia areata, you can see that it's very clean. There's no fringe sign. There's even a little bit of lightening where her hair used to be, and you can see how quickly the hair fell out because there's a change in color where she didn't have sun exposure, but it's in the same area. Going back down now to the bottom left, frontal fibrosing alopecia, or FFA, is another potentially confusing diagnosis that people sometimes think is alopecia areata. This is a scarring form of hair loss where white blood cells attack the hair follicles, but they don't just put them to sleep. They actually try to kill them off. So these patients have a completely different disease, oftentimes have eyebrow involvement. It's the same way that alopecia areata can be involved, but it's a very different process when we look at it with our trichoscopy and when we look at it under the microscope. Seborrheic dermatitis is another one where you can have just short-term hair loss when there's active disease. Seborrheic dermatitis is kind of like dandruff, or a little bit more severe dandruff. And you can have just so much inflammation that people have a little bit of hair loss. And when you treat their seborrheic dermatitis, their hair grows back. So oftentimes people will think that when they see this around the frontal hairline. So now we know things can look like alopecia areata, but not be alopecia areata. And that's why you need a board certified dermatologist to help you figure out what indeed you have if there is a question so that you get the right treatment. So let's look at all of these cases. So this is another form of hair loss that is not alopecia areata. These are other forms of hair loss. The one on the left and the middle one are both central centrifugal cicatricial alopecia. They have patchy hair loss. Oftentimes it looks like some of the hair is regrowing. But again, if we look at it close up with our trichoscopy, we can see that there's perifollicular white-gray halos. There's follicular dropout, which you never see in alopecia areata. And oftentimes, lots of other signs that are part and parcel of these diseases, but not alopecia areata. And then we also have patients who can have discoid lupus or DLE, discoid lupus erythematosus lesions in the scalp. They typically are also scarring. Early on, they can be very confusing with alopecia areata. So when patients are not behaving in the way that I think they should, but I think they have alopecia areata, then that's when we do a biopsy. So if the diagnosis is in question, then we really need to decide how to get to the correct diagnosis, because that's going to be the clincher. Most of the time, it's quite easy. We don't have to do biopsies. We don't have to do a lot of extraneous blood tests for sure, but sometimes we do have to do a biopsy. Now, something that some of you may or may not be aware of is that there have been several studies now that point to the fact that Asian and African American patients probably have an increased prevalence of alopecia areata, at least in the United States, as compared to Caucasian patients. These were the first two studies. One was a study from our own National Alopecia Areata Registry. And of course, people said, well, maybe this is not characteristic of the entire United States because only certain people know about National Alopecia Areata Foundation or have donated their genetic materials to be evaluated. And then there was a cross-sectional study, very large study of over 63,000 women from the Nurses Health Study and the Nurses Health Study Part 2, another almost 89,000 women. And again, African-American women had increased odds of alopecia areata compared to white patients. So we had a lot of data sort of building up to show this. And then we had a very nice article written just this year in JAMA Dermatology, looking at a very large electronic medical record study where about 1,800 of the patients had at least one code for alopecia areata. They looked at many thousands, and about 67% were female, about 33% were male, and that's what we're seeing. We're seeing a female predominance, even though back when I was a resident, we used to say it's same in all ethnicities, it's the same in all genders, but what we're finding out is that's not actually true. So Asian, Black, and Hispanic Latino patients were actually much more likely to have alopecia areata than Caucasian patients. And we did see in this particular study a very small number who had alopecia totalis or alopecia universalis, at least in this study representation. So let's move on to treatments for alopecia areata. So we have lots of treatments, and whenever we have lots of treatments for a disease process, that might mean that there's not one good one. However, we'll talk about how this field has really just boomed in the last year and why we are starting to see very specific and very wonderful treatments for this disease. So first of all, we have had corticosteroids for many, many years, and this has been really the mainstay of treatment for alopecia areata patients. Topical steroids, often used primarily in those who have less than 50% hair loss. Intralesional steroids, again, not for total scalp involvement. And then in some cases, we actually do systemic steroids in order to get the inflammation down, oftentimes as we're trying to get them onto another treatment that will maintain the hair. We've used light therapy, UVB or ultraviolet light B, Sorolin plus ultraviolet light A has been used, and you know, with some minimal success. We also have tried topical and oral minoxidil. Some of you may know the topical minoxidil by its trade name, Rogaine. And it can be helpful as an adjunctive agent in the treatment of alopecia areata. Anthralin is an oldie but a goodie, often used in children, where it actually was supposed to be used for psoriasis patients where they have thick, scaly lesions, and it goes on and kind of thins the skin. Well, we have great treatments for psoriasis now, so we don't really use anthralin very much, but it can cause a little bit of irritation and therefore trick the scalp, bring some white blood cells up to the scalp that don't have to do with alopecia areata, and sometimes they can get hair growth with that. Methotrexate is an oral medication. It's an oral anti-inflammatory medication that we use a lot in dermatology for psoriasis and also for eczema. It's also used in rheumatology for rheumatoid arthritis and psoriatic arthritis. And it's used in very, very large doses in cancers of the GI tract. But we use it in very small doses in our patients. And we can see that at times it can be very helpful. And I'll show you a study in a moment for patients who aren't candidates for some of the newer drugs and how we can use it to improve hair loss in patients with alopecia areata. We'll spend a lot of time on topical and systemic JAK inhibitors in just a moment. So I'm not going to spend too much time on that, just to say that another word for this is Janus kinase inhibitors. And this is a pathway in the immune system that was found about 30 years ago now. And it's just been amazing how many different forms of inflammatory disease in the body, just not just in the skin, but in the body, that it can actually sort of modulate. So we have treatments for rheumatoid arthritis, for myelofibrosis, for psoriasis, for eczema, for alopecia areata, etc. Some folks have tried antihistamines. I've used this many, many times and never found it to be helpful, but there is a little bit of data out of some of the Asian countries about this. Of course, always in my treatment profiles, a referral to the National Alopecia Areata Foundation because they do support patients so well. I think it's important to understand wigs and hair pieces for our patients who want them, and also hair cosmetics. There's lots of ways to sort of cover and camouflage hair loss. And we won't go into all of these today, but just to throw it out there so you know that we're thinking about it. There's scalp microneedling, which we haven't seen to be an amazing treatment, but I'll give you a little bit of data on it. Platelet-rich plasma, that's what PRP stands for. People have used that again, not with great improvement. Different kinds of oils, cannabinoids have been also tried. We have very little data. And then whenever you have something that's a chronic inflammatory condition, I think self-care is really important. And so I wanted to point that out. I'll go through a couple cases as we go through our talk today as well. So this is an older patient of mine, or an older case of mine. And just to show you that older treatments can work. So some years ago, I used a treatment that I didn't have on that list, but it's called squaric acid. And it's a way to sort of make an allergic reaction. So a contact allergy reaction on the scalp allowed, again, white blood cells to come up to the scalp and sort of squeeze out the alopecia areata white blood cells, the lymphocytes that are attacking the hair follicles, and allowed his hair to grow. So it's a 13-year-old young boy who would come in every day with, every time he visited, with his hat on and his head down. And he came in 6 months, and he had his hat on, he had his head down. And I walked in the room and I thought, oh no, it's not working. And then he lifted his head and he smiled and he took his hat off and his hair was growing in very nicely. So we don't just abandon old treatments because we have new ones, because sometimes the old ones can work. Now, not everybody is going to do squaric acid dibutyl ester, but some people might. And I think that as a result of being able to do this, we need to consider that for some of our patients, especially those who are not candidates for some of the newer medications. Now, sometimes when we treat with minoxidil, this is one of my alopecia areata patients who were using adjunctive topical minoxidil. She got a little hairy. So that's what this is called, hypertrichosis. So too much hair. She just dialed her minoxidil back, but used it a little bit, and the hair improved, and she's not super hairy anymore. And she's actually someone who has been on social media now, helping lots of other people get through alopecia areata. She's a lovely, wonderful patient who, thank goodness, has done well. So this is that inflammatory pathway that I was talking about. So, we had this inflammatory pathway, that was discovered by very smart, people who work in the lab all the time, not dermatologists, but, basic scientists. And Dr. Angela Christiana, who is a scientist in New York, was doing research on mice, and she was able to find that the certain kind of cell, certain kind of white blood cell called an NKD2 T cell was necessary and sufficient to induce an alopecia areata-like variant in mice. And she took it one step further and recognized all the different chemicals that were needed and all the different mechanisms that were needed in order for this process to occur. And she was the person who really elucidated this, not just in mice, but also in people. And that's the article, the landmark article, we call it, that was published in 2014, showing the very first patients with the use of a drug that we don't use for alopecia areata called ruxolitinib, helping with return of hair growth. And so that's what all this stuff on this page is really talking about, this mechanism, this really important discovery, uncovering how we can actually affect and inhibit the signals that cause alopecia areata. We can't cure it, but we can certainly treat it with these drugs that inhibit this pathway. And so we'll talk a little bit more about that in a moment. So how do we sort of, put this together? Well, it used to be none were FDA approved, but now we know JAK inhibitors are, but none of the other things that we've talked about. Sometimes I separate things out into patchy and totalis, but now the lines are a bit blurred. We have topicals and injections. We tend to use those more in patchy alopecia areata, but I also use the topicals in the patients with totalis and universalis because they're nice adjunctive treatments. But we do tend to use the prednisone or the steroids, the methotrexate, contact immunotherapy like that young man got, and JAK inhibitors in folks who have more aggressive disease. Now, what's interesting is that once this pathway was found, there was one pretty well-known JAK inhibitor around. It was called tofacitinib. And the folks up at Yale, Brittany Craiglau and Brett King, actually were seeing a lot of alopecia areata patients because he's a hair specialist and she's a pediatric dermatologist. And they started using a lot of tofacitinib in their children. They used it for severe patients. They used it on the eyebrows. They used topical on the eyebrows and eyelashes, which we'll talk about in a minute. We don't think that the topical works very well, but they gave it a good go to show that tofacitinib, a JAK inhibitor that will not be available for alopecia areata at any point in time, actually could work. They were getting it in different ways. And then the company actually started to allow people to use it because it was so important a drug. That's no longer allowed by the company that makes it. So this is one of my patients who's a 14-year-old before and after. So before, he had very, very significant hair loss with what we call vellus and intermediate hairs, so very small hairs. They were not terminal hairs. And after tofacitinib, he grew his hair back, and his mother says his hair is a lot more curly than it used to be. But as you can see, JAK inhibitors can be very fantastic in the way that they actually improve hair growth in alopecia areata. Here's another patient, and you can see that this patient had also very severe hair loss, and he was a teen as well, and he had excellent hair growth. One of the side effects of the JAK inhibitors, particularly tofacitinib, is that you can have acne. Now, most people would be okay with that as a potential side effect. We'll talk a little bit more about some side effects that you can have with medications that are maybe a little bit more serious, but acne we can treat. So we just treated it and he was very happy with that. So let's just do a quick update. So what drugs are available or going to be available? Well, ritlecitinib is the newest drug approved, also called Litfulo. And that was approved just within the last month. It'll probably be available in another 2 to 3 weeks. The company is trying to get their distribution process together. The FDA doesn't tell you when they're going to approve your drug. They just do it, and then you're kind of left scrambling. So they were very ready, but they're also, trying to get it quickly to the people that need it in the right ways. And this is what we talked about, a JAK inhibitor, but also inhibits TEC kinase, which is another kinase in the JAK-STAT pathway. And this drug is going to be approved or is approved for ages 12 and up. Which is unlike the other medication that's approved, and it'll be a 50 milligram tablet. Baricitinib or Olumiant has been approved now for not quite a year. It's oral, reversible, and selective JAK1 and JAK2 inhibitor. And we won't get too much into the details, but we know that JAK2 probably doesn't have a lot to do with alopecia areata, maybe helps a little bit, but this drug is only approved for adults, and you can take either 2 milligrams or 4 milligrams daily. And we've been seeing, as we use it more and more, most people do quite well on the four. And so we tend to do the 4 milligram dose in the adult patients because they're the only ones that actually get to take this. And then there's another medication that's called duoruxolitinib, and it's also called CPT 543, and that's still in long-term open label studies. So we know it works. They have had one episode of someone having blood clots on the 12 milligram tablets. So they have taken the 12 milligrams out of their study. So it's 4 and 8 milligram doses. And again, another medication that is working quite well. So we'll see when they have everything completed, how quickly that'll come to market. So the baricitinib, or the Olumiant, you can see here, this is kind of a scientific look at how it works. But if you're here at 0 with, very little hair, you have not much hair to start with, or whatever you start with, and then you take the medications, and you can see the medications are the blue and the red lines. The people that were in this line didn't get any medicine. You can see the people who took the medicine did a lot better. So their SALT score, or the score that we used to measure the alopecia, how severe the alopecia was, got a lot better. So they actually improved a lot. Okay. And then when we look at the absolute SALT score, this is more like what we're used to seeing, where the trend goes up instead of down. Again, the two groups that were taking the 2 or the 4 milligram tablets of Olumiant did very well. The people that were on the 4 did better, but the people that were on the 2 milligram did not do as well. Sorry, we switched very quickly. But this is the retlicitinib data, and I took this from a very nice poster by Dr. Bloom Patavi, who's a hair expert in Germany. And she really had a nice study, and it's very complicated looking, but it really isn't. And so I'm going to show it to you, and you just have to follow along. So for the first square, all you need to know is that the important things are the different doses of retlicitinib. Okay, there are different ways that they gave it, but the placebo are these 2 lines here. These lines, this gray line here, and then a switch over to the medication. So they switch over to the medication. So everybody got medication, but they switched over to the medication. But you can see where they were on placebo, they weren't doing so hot down here at the bottom, but they switched over and they were able to reach up to where the patients were taking the retlicitinib the whole time. So you can see again, data point after data point, that these medications work for patients who have alopecia areata. So that's what we want. We want improvement in alopecia areata, however we look at it. Clinical improvement that patients can see, the SALT score, which is the way we measure this in trials. But either way, it's a great outcome for our patients. Not 100% outcome, because not everybody responds to these medications. How do we pick a medication if we have 2 medicines that you could possibly take? Which one is better? No one knows. No one will be able to tell you that. So you have to look at the medication, and you and your doctor have to be the ones to sort of judge where you're going to start. And if one doesn't work after you've tried it for 9 to 12 months, then it will be certainly prudent to try the other one, because they are a little different. But you can't look at a patient and tell which one they want. The only one you can do that with is Litfulo when it's children, because that's the only one that is for ages 12 and up. So we talked a little bit about the fact that there are potential side effects to these JAK inhibitors. So they're not all, happiness and light, that you can get infections with them. You can get blood clots. That's what thrombosis is. You can have cardiovascular events. That means heart attack, other cardiovascular events, malignancies, both in the blood and solid tumors. So we have to be very careful about who we choose to give these to. We're not going to give them to people who have a history of cancer. We're not going to give them to people who have a history of blood clotting. We're not going to give them to people who have ongoing infections that are acute at the time of treatment. We're not going to give them to people who have a lot of cardiovascular history. And your labs have to be normal. And we do monitored labs while we're on these medications. So you have to have a white blood cell monitored, hemoglobin, just your red blood cell count, your liver function tests, your lipids or your blood fats. All of that has to be monitored in addition to at least once a year, making sure you don't have tuberculosis. So we usually do that in a blood test as well. So when you start a JAK inhibitor, it's not just let's take the pill and off we go. Most people are very, very safe and do well, but we have to do our due diligence as good physicians to make sure that we get these medications to the people that really need them, but also the people who are going to be the healthiest on them. So emergent treatments, I said I'd talk a little bit about this. I won't spend much time. These are all things that people have talked about. I talked about them a little bit, but none of them have really reached to the potential that we had hoped. So we probably won't be using them long term or significantly in anytime soon. Lots of people like to use natural oils for their hair and scalp, and they feel that that helps their alopecia areata. And I just want to tell you, they don't really work for that. So you might be doing, excuse me, more harm than good if you do a lot of oils, because if you're also doing a topical medication, it may not be able to absorb while you're taking all these oils. So be very careful about using oils on your scalp. Unless you speak about this with your doctor, it might be actually working against the process of growing hair. Just wanted to mention a couple words about wigs. It's much more complex than just saying, hey, go to a wig shop. You know, you have to get the right wig, you have to be able to maintain it, you have to use it properly. And so I think you need a multidisciplinary approach. I try to work with local wig shops in my area and discuss, kind of price points with patients. Kids often try to get them free wigs. We have to talk about what kind of wigs. Natural hair wigs are much more expensive than synthetic fiber wigs. There's lots of glue and non-glue wigs. And the problem with glue on wigs is that you can't treat your scalp. So if you're not in a treatment mode, that's great. But if you're in a treatment mode and you want to do topicals, it might not be so great. And then, of course, there are a number of hair cosmetics. And it just is important to talk to your dermatologist about this and see where they recommend that you go, because some people are very good about knowing which shops in the area are good. I mentioned cannabinoids. People love to ask about this. There's no scientific basis for treatment of alopecia areata at this point. So we have to really look through more. We have to really do more research and get more data to make an assumption about how cannabinoids are going to help. So in summary, I like to say, don't believe Dr. Google when it comes to treatments for alopecia areata, because Dr. Google is often wrong. The National Alopecia Areata will give you the straight facts, nothing but the facts, and give you updates as well. And remember that self-care with meditation and overall, healthy eating and healthy approach to your diet will help, just in general, making you feel better. It's not necessarily, there's nothing that you can specifically eat or not eat to help your alopecia areata, unfortunately. Work with your board certified dermatologist to pick the right treatment plan, and it may have to change. Everybody's a little different, and nobody's going to respond just the same way as the last patient that was in their office. Bring your questions to your appointments in a list form to make sure you cover all the topics. Think about it a little bit beforehand. And finally, we're getting a lot of wonderful scientific information about new medications. It's very exciting. These medications are well studied. And so in the future, we'll have even more specific treatments, and that makes our future very bright. So thank you very much for your help today. I also want to just thank my hair loss team, Dr. Jorge Larondo, who was a visiting professor here for 1.5 years from Santiago, Chile, who's actually gone back to Santiago, and Dr. Ivy Obami, who is my research fellow. Thank you so much. And with that, I'll stop my share.
Great. Thank you so much, Dr. McMichael. That was really informative. You covered a lot in a quick amount of time, which is great, because it's hard to get an overview like that. So now I want to invite everybody to submit questions. If you can, try to keep your question as general as possible, so that we can get through more of them. We have about 180 people with us right now, so that's exciting. And I appreciate all the reactions. You can see the little hearts and things.
Yes, thank you guys. Thank
We
you.
appreciate you and having you here. So I will be going through some of the questions, and
Mhm.
we will do our best to get to as many as we can.
Okay.
This person has a question about JAK inhibitor treatment in general. Do they affect other autoimmune disorders? This person asked about Graves' disease, but if you're somebody who's taking one, if you have alopecia areata and something else, would you expect that they might take
Mhm.
care of more than one?
So interestingly, and I didn't focus on this because we didn't have all the time in the world, but we also use JAK inhibitors, as I said, for psoriasis and for eczema. So if you're, and we often see that people who have eczema have an increased risk for alopecia areata. So if you have both eczema and alopecia areata, JAK inhibitors might be a great thing, because they can actually address both of those issues. Now, having said that, if you have certain autoimmune diseases, JAK inhibitors might not be what you want to take. So you would have to talk with your rheumatologist or your primary care doctor to make sure that that's a good fit for you, because sometimes it can be, but it's not always. So unfortunately, I can't give a more specific answer. So the answer is yes, it can be helpful, and sometimes it's not.
Yeah, so it depends.
Hmm.
Okay, thank you. Here's another question. This person said that they've had success on one of the JAK inhibitors, and his or her question is this a forever drug?
Well, the question is great because what it underscores is that alopecia areata is unfortunately a long-term diagnosis. So I'm not going to say forever because none of us are here forever. But alopecia areata, once you get it, it's your diagnosis. Now, does it mean it's always active? No, but it does mean that you have it for the rest of your life. We have no cure for alopecia areata yet. So if you're going to take a medication to treat your alopecia, it's going to be long term. Now, what's the decision about how long you stay on a particular JAK inhibitor? Well, that's going to be determined by your laboratory testing, how you feel on the medication, how well it's working, and all the other things that are going on in your health. It might be something where you could actually decrease the dose and take less. There are people who go into remission at times and you can actually come off of it, but that's unpredictable and no one can tell you how you're going to specifically react to the medication. So it's not so much the drug that's forever, it's the chronicity of alopecia areata that's the long-term problem. And until we get a cure, most treatments are going to be long-term.
Thank you. Is there an antibody test for those who are diagnosed with alopecia areata, or is there a genetic test for alopecia areata?
So that's a good question because it gets into the sort of the basic science of this. So when folks who are basic scientists look at genetics, there are certainly ways that they can see that certain patients who have alopecia areata have certain kind of genetic makeups. But there's not just one, and there's no test that's a commercial test that one can get. Those are really explicitly in basic science studies where people have, donated either their saliva or their blood or their skin to do this specific study. But there is no test at this point that is blood related or any even saliva related or genetically able to diagnose if you're going to get alopecia areata if you haven't already had it. So unfortunately, you can have genetics for something but never show it. So we wouldn't be able to judge it based on that. And then you might have genetics for something that we don't know yet and have alopecia areata. So unfortunately, there's no test, no blood test that's going to tell you whether you have it or not. You have your wonderful board certified dermatologists that are going to help you diagnose your disease.
Okay, thank you. This is a question. I am recently diagnosed and was told it would be better if I stopped coloring my hair. Is that true?
Well, I'm not sure exactly what your dermatologist was seeing, but it may be that you had some hair shaft abnormalities as well, some breakage or, maybe some fragility. And perhaps that was the reason they said that. But in my opinion, hair color and hair dyeing doesn't really have much to do with alopecia areata. So the good news is that most of my patients who want to dye their hair, for instance, if they get that gray hair growing back and they want to dye their hair, that's fine.
Okay, it's good to know. As far as scalp health, what oils are best for African Americans with alopecia areata who are not trying for regrowth, but just scalp health?
Right. So I am not a proponent of oils on the scalp, period. That is not where I come down for people of color or people not of color. There are many ethnicities and folks in different areas of the country that use oils for their hair shafts, and that's okay. For scalp health, if you have scaling or you have itching, you need to actually seek treatment and actually treat that because you shouldn't have itching and scaling of your scalp. It's a common disorder to have sebderm, particularly in African American patients, but it is not normal. So oils that are not prescription are not for your scalp. So scalp health is washing your hair every 1 to 2 weeks with gentle shampoo, conditioning your hair. And if you have other things going on, you might need medications like topical steroids, etc. If you're not treating your alopecia areata, you can still treat sebderm or itchy scalp. So my recommendation is if you have an issue, you need to go to see about that with a board certified dermatologist. If you're not having an issue, gentle hair care practices are what I recommend. So things that don't put a lot of tension on the hair, that have a lot of pulling on the hair, not a lot of gels, all of these things can be damaging to the hair that you do have.
Okay, thank you. This question, since this is alopecia areata 101, and you were talking about different kinds of alopecia, this is a more of a general or clarification on types of hair loss.
Mhm.
Where does lichen planopilaris hair loss
Mm.
in the hair loss world?
Yeah, so lichen planopilaris is a form of scarring alopecia that can be patchy. I didn't show it because, again, we didn't have time for everything. It can be patchy, and there is a variant of it called pseudopelade that looks very much like alopecia areata, and that's actually what pseudopelade means. It's like it's in French, like alopecia areata. So it's scarring, and it's actually FFA or frontal fibrosing alopecia is a variant of lichen planopilaris as well. So scarring, sometimes a mimicker of alopecia areata, but again, with hairs that are damaged to the point that they're fibrosed and a very different inflammatory process than alopecia areata.
Thank you. Is there any evidence that stress precipitates hair loss in alopecia areata?
Yes, so that's a question that I always get. I've had a lot of stress. Is this why I have hair loss? Well, stress is very difficult to measure. Don't have great measures of stress, and we have 3-year-olds, 2 years with very non-stressful lives who have alopecia areata. So I think that the stress connection is really built up mostly on social media and uninformed sources. So stress affects every form of medical condition that there is. So if you're prone to have headaches and you have stress, perhaps you'll get more headaches. It's not causing your headaches, but maybe it's making them appear more. And that's the same way it is, I think, for any form of hair loss. And now you can have medical stress, actual physiologic stress, like a surgery, general anesthesia, um, car accident, a stroke, anything like that. But it's not the mental stress, it's the physiologic stress that maybe brings out the first flare of alopecia areata. Again, it doesn't cause it. It was something that is already there genetically, and it just happened to come out at that time. So stress and hair loss is not so cut and dry that you should think about, oh, I had, really stressful day. We live pretty stressful lives, and it's important to take care of yourself and try to reduce your stress as much as you can, but it is not the cause of alopecia areata.
Thank you. Two questions related to pregnancy and JAK inhibitors. Are there any risks with JAK inhibitors and pregnancy outcomes, or similar question, are JAK inhibitors safe to take during pregnancy?
Absolutely not. You would never, ever, 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 ever take JAK inhibitors if you are pregnant or if you're about to become pregnant. So we do not recommend that. Nope, not at all.
Okay.
Now, having said that, can you take it, go off of it, let it wash out of your system, and then get pregnant? Yes, you can do that. But no, not while pregnant, and not while you're trying to get pregnant.
I have alopecia areata and have started losing my eyebrows and eyelashes. Is there anything I can do to help these areas regrow?
Sure, sure. You talk to your dermatologist about how they would approach it. There are many different things that you can do. You can do topical steroids, low dose. You can do intralesional steroids, low dose. Sometimes when you have JAK inhibitors on board, you can actually get improvement in your eyebrows and eyelashes. And sometimes we use minoxidil orally or topically. It's sort of the poor man's way of doing eyebrow improvement with minoxidil a few times a week. So you can ask your dermatologist what's the best approach for you, but sure, you can do different things for it. It is harder to treat, I will say, because in that area, you don't want to do too much that's going to be damaging to your skin in that area, but you can do it.
Okay. Is there any research that shows that acupuncture helps?
Hmm. No research, but again, if it's a way for you to sort of self-care, um, I think that for a lot of different things, it can make you feel better overall. And if you feel better overall, feel, more healthy and just more yourself, I think that helps no matter what condition you have. So it's certainly something I would say if you like it, do it. I don't think it's going to be a cure or a real treatment, but it can be helpful as an adjunct.
Okay. I've seen a couple of questions that ask questions about whether if you can see hair follicles or if you can't see hair follicles, will a treatment still be effective? So this question in particular says, does it matter if you still have follicles or not in regards to the hair growing back when taking medication? So I'm kind of interpreting, but I think for some folks, maybe they feel like they can see hair follicles sometimes,
Hmm.
but other times they can't, or there are parts where they can't see the
Right.
follicles.
Right. So when you're looking at your scalp or someone's looking at your scalp just with their own eyes, you may or may not see the hair follicles. Some people's hair follicles are not very, you know, prominent. So you don't see them, but they're there. And we can see them with our trichoscopy. So that's our handheld dermatoscope or, handheld magnifying glass with light. So we can often see the hair follicles, even though you can't see them with your naked eye. So as long as the hair follicles are there and you have a diagnosis of alopecia areata, there is a potential chance that you can actually regrow hair. Now, if you have a scarring form of hair loss where we do actually lose the follicles because there's fibrosis and scar tissue that takes the place of the hair follicles, no, we would not expect hair growth in that circumstance. So, you can't just look, kind of as an untrained eye and say, oh, they're follicles, they're not follicles. That's sometimes a little tough. And then, of course, if we are really caught up in differential diagnosis and we're not sure, that's when we do a biopsy. And then we really see whether there are follicles there or not.
Is alopecia areata genetically transmitted to other generations, as for example, from father to son?
Yeah. So, anything that's genetic, the material, genetics are genetics, right? You do pass things down. So you can see this in families sometimes. But interestingly, when family studies have been done, we don't see that it's, sort of a one-to-one. So if you have it as, the father, your kids are definitely going to have it. It's not really like that. And so it's hard to predict it. It's actually kind of rare to see it in families, but it does occur. So the answer is it's rare, but potentially.
I have a burning sensation before I see increase in hair fall. Is this common with alopecia areata?
It's not common, but I would say about 15 to 20% of my patients have that. So yeah, it's been described. Some people get a red spot, and it's just another marker of inflammation. So when white blood cells come to the surface of the skin, they kind of send out little, markers, different kinds of chemicals. We call them chemokines, and that attracts more cells, more white blood cells, and more chemokines. And that whole process, is what we call inflammation. And inflammation, the signs of inflammation are, warmth, redness, maybe pain, tenderness, swelling. So you can have those things. It's just not so common, but I do have patients who they don't even have to be able to see it. They'll say, oh, my spot is right here because I can feel it. I felt it when it started. And so they're really quite good at identifying them because they can feel it, but not everybody can.
Okay. Would androgenetic alopecia be treated the same way as alopecia areata?
Oh, absolutely not. So pattern hair loss or androgenetic alopecia is a non-inflammatory form of non-scarring hair loss that is what we call pattern hair loss. So it's hair loss that is genetic to some degree, And typically in women, it's sort of in the crown of the scalp, but in men, it's more in the temples and frontal hairline. And it is because this doesn't work through that jack stat pathway that I described, it would be a completely different way to approach it. Now, having said that, minoxidil can be used in a lot of forms of hair loss because it just tells the hair to grow. It prolongs what we call the anagen time or the growth phase. So we use it in a lot of forms of hair loss, and it can be kind of confusing. Like, well, why does it work in this and then it works in that? Well, because we use it adjunctively in a lot of different forms of hair loss, but we certainly wouldn't treat pattern hair loss or androgenetic alopecia with anti-inflammatory treatments the way that we do alopecia areata. Very different.
Thank you for that clarification.
Mhm.
This question is from someone who's recently diagnosed, has small spots, and wants to know, and is 65 years old, and wants to know about the prognosis for individuals
Mhm.
that age.
Yeah. Think of alopecia areata as sort of a disease of younger folks, and so 45 and under, but that doesn't mean that it has to be. Sometimes it hits whoever, hits you as a 65-year-old woman. We don't, we can't give you a specific prognosis. That would mean that I would have to have my crystal ball here, and I unfortunately don't have one yet. I'm working on it. But I don't have one yet. So what I would say to most patients is that when you start out with small spots, often you stay with small spots if it's been a while. But we just don't know. So you'd have to sort of make sure you just follow it, and if things progress, then you would certainly start treating more aggressively. But for somebody like that, if they can be easily covered, you don't even have to treat. I have patients who come in all the time and say, "Oh, I had a spot of alopecia, and I thought I would talk to you when I came in, but it went away." And it just self heals. So that's very nice. It's one of the few forms of hair loss where that does happen, and we love it when it does. Doesn't always. And so my hope for you is that that's what happens. But if not, got to get yourself a great dermatologist.
Question about another treatment or possible treatment, finasteride. I'm not sure if I'm
Mhm.
pronouncing it
Yeah,
correctly.
finasteride. Yeah, so
About it.
finasteride is a 5-alpha reductase inhibitor. Again, that's one of the medications that we use for pattern hair loss or androgenetic alopecia, not one that we use for alopecia areata. We use it in other forms of hair loss sometimes, but never in alopecia areata. Would not be on my list at all. So that's why it wasn't on my list in my slides, because it doesn't really work for alopecia areata. So, um, you know, again, you have to be very careful about what you read online and what Dr. Google says, because sometimes they're talking about a whole different form of alopecia than alopecia areata.
Why does regrowth come in gray? Or can you talk about hair color and regrowth?
Yeah. So, we don't know that answer 100%, but what we do know is that some of the lymphocytes appear, some of the antibodies that are attracting the lymphocytes, I should say, are attracted to the pigment in the hair. So, you've heard people say, "Oh, someone went gray overnight." Well, many times what that is alopecia areata, and people didn't know they had so much gray hair, and alopecia areata came very abruptly and just didn't attack the gray hairs. And so we don't know exactly why that is, but it is not it's not to say if you have darker hair, you're more at risk. And if you have gray hair, you're not at risk, because I have patients who have gray hair and have alopecia areata. So it's just one of those kind of funny things that we've followed over the years, and we've been able to measure it to some degree, but we don't know all the ins and outs of why it occurs.
Okay, here's a good one. They're all good, of course. Can COVID trigger alopecia?
Ah, so when we were seeing lots of COVID, the form of hair loss that was the most common was a form of hair loss called telogen effluvium. And that's a form of hair loss that is basically one of those physiological stress kinds of hair losses. It's not like I had bad days last week and now I'm losing my hair. It's, I had an infection, I had surgery, I had a baby, I had, a motor vehicle accident, I had whatever you have. And so when your body is physiologically stressed in that way, and the important word is physiologically stressed, it says, let me focus on the thing that I need to fix. I need to heal this knee. I need to, get this person's infection better. And it switches its energy over to that process. and it takes the energy away from hair because, sort of if you look back in our, kind of caveman days, if you believe in that, when our bodies got stressed, we had to conserve energy and work on the things that the body felt were important. And so hair growth wasn't as important. So it gets switched over. But the good news is once you get that thing fixed, you regrow the hair. So so was the question again? So yeah, so COVID. So I think that most of the patients that had COVID associated hair loss, it was telogen effluvium. Could you have a very severe COVID case and your alopecia areata flare? Sure, that could happen, but we didn't see a lot of that actually.
Okay, thank you for that answer.
Mhm.
Is there evidence of alopecia areata affecting other organs in the body?
Nope, not at all. Just the hair follicles. Like I said, you can have associated other conditions that are going on in the same person, but alopecia areata itself, so that's good news.
Yeah. Any tips on emotional health when dealing with hair loss?
That's a great question. I think that having somebody to talk to is really important. So whether that is a family member who understands your plight, or it's a counselor, someone in your place of worship, an actual psychologist or psychiatrist, I think all those people can be helpful. Another group, the National Alopecia Areata Foundation, can hook you up with folks to talk to. There's lots of you know patient groups that meet in different areas of the country, and you can kind of just talk about it with people who have it. You can go to the big meeting that they have every year. It's usually in June. All different places, all different fun places you can go and just hang out and chat. So I think having an opportunity to talk about it, to really let it out is a nice thing. I think that helps. But when you get to the point where you have true depression and you really start thinking dark thoughts, I think that's important to get help from a mental health professional. You don't want to play around with that. You want to just go ahead and get someone that really knows what to do and is going to really pay attention to what you need specifically overall. But I think that a very caring physician, dermatologist who's taking care of you can be very helpful. But I don't think they can do it all, unfortunately, because most of us don't have, counseling degrees, and we don't have the psychiatric training to do it. There are a couple of clinics around the country that have both psychiatrists and dermatologists in them. They can do it, but we don't have that in most offices.
I think that that's probably a good place for us to end because it's almost the top of the hour. And, thank you for mentioning NAF support resources. And I'll talk about it again at the end of this webinar, but please naf.org/support for more information on that. This has been great, Dr. McMichael. Thank you for going through rapid fire questions and providing so much information to the audience. We really appreciate it. And thank you for being here.
My pleasure.
I'm going to share my screen again and just wrap this up for everybody. Okay. Thanks again, Dr. McMichael, and thank you to the audience for being here. We hope that you will share your feedback on this webinar with us and help us plan future webinars. You'll see a link to a short survey that'll pop up in your browser window when you turn off the webinar, and we really appreciate your feedback. There we go. Something new happening with NAF. We are excited to announce the inaugural Walk for Alopecia. You can join the Alopecia Areata community for a walk taking place on September 30th. We're going to rally coast to coast to raise funds to support our community, educate the public, and empower people living with alopecia areata everywhere. The Walk for Alopecia will bring the alopecia areata community of family, friends, coworkers, and healthcare professionals together to drive research for better treatments and a cure, increase support, advocate for change, and reduce stigma. Please sign up today. And if you sign up your team by this Friday, July 21st, you'll be entered into a drawing to win a $100 Amazon gift card. So go to naf.org/walk to get more information about this exciting event. And join us for our next webinar, Preparing for Back to School, Insights from a Teen and Young Adult Panel. Heading back to school is an exciting time, but for young people with alopecia areata, the thought of starting a new school year can be overwhelming and scary. Whether someone's heading into elementary, middle school, high school, or even college, it's a time with lots of changes and challenges. NAF Support and Education Director Judy Williams will join a group of young adults and teens who are living with alopecia areata to help answer all the questions you may have about how they prepare for a new school year and how they've managed their school years in the past. This live webinar will take place on Wednesday, August 16th at 7 p.m. Eastern, 4 p.m. Pacific. Registration is now open, and we hope that you will join us there. And as we said before, don't forget all the resources that NAF offers to the alopecia areata community, including support groups, a youth mentor program, the legislative liaison program, news and webinar links, and how to get involved. To learn more about NAF and the resources that we offer, please visit naf.org or email us at support@naf.org. And that concludes today's webinar program. Thanks to everybody for joining us today, and we look forward to seeing you on the next webinar.